Next, we're going to have Dr. Raegan Durant speak. Dr. Raegan Durant, he is an associate professor of medicine at the University of Alabama in Birmingham, the Division of Preventive Medicine and General Internal Medicine. He's a native of Alabama. He got his BS from Howard University in Washington, D.C., and he got his doctorate at Johns Hopkins University. So please give it up for Dr. Durant.
First of all, I want to thank you for the opportunity to address this group. It's my humble pleasure to appear today to speak about such an important topic before our congressional staff, representatives of the Men's Health Network, my esteemed co-presenters, and other guests. So thank you. To start, I think it would be instructive to share my general frame of reference for healthcare based on our local demographics and our patient population. I live in Birmingham, Alabama, the most populous city in Alabama. The Birmingham metro area is comprised in large part by Jefferson County, which is where all of our patients reside. According to 2017 population estimates by the U.S. Census Bureau, Jefferson County has approximately 660,000 residents. Of those residents under the age of 65, approximately 70,000 are uninsured. In general, rates of uninsurance are the highest among the poor, African Americans, states like ours that without the recent Medicaid expansion as well. Included in your packet, I think, is a more detailed description of Cooper Green Mercy Health Services, where I serve as medical director. But briefly, it's a primary care and multi-specialty ambulatory care center providing on-site clinical services as well as a full complement of ancillary services such as pharmacy, lab, and radiology. Cooper Green is wholly supported by earmarked public Jefferson County funds and represents a collaborative effort among our county commission, county managers, and our own institutional leadership. At the beginning of fiscal year 18, we recorded over 16,000 enrolled patients, 67% of whom lacked any insurance at all. Our population is 78% African American, and almost 50% report earnings equal to or lower than the federal poverty line. Hopefully these data will give you a snapshot of our patient population that faces significant financial challenges to receiving preventive care such as prostate cancer screening. While statistics such as these are helpful in framing the context, the experience of prostate cancer screening can best be illustrated by a patient example. I've obtained permission from one of our patients to share his recent experience with a diagnosis of prostate cancer. Mr. A is a 56-year-old man who first presented to us in primary care in 2016. At that time, he already had a number of established diagnoses, including heart failure, high blood pressure, obstructive sleep apnea, and emphysema. As a result, he was taking 21 medications daily. Unfortunately, two of his conditions in particular, the emphysema and the heart failure, were difficult to manage, and Mr. A had required repeated admissions to the hospital over the course of the last 2 years. In addition to these readmissions, Mr. A also had his hands full at home, living with an elderly mother and at times serving as her primary caregiver. Around the same time, he also became guardian to 2 young grandchildren. Because of his enrollment at Cooper Green, he did have access to both outpatient and inpatient care. Unfortunately, given the perpetually tenuous state of his health between hospitalizations, most of his time in clinic was spent on treating his acute problems rather than preventive care. He did receive those preventive measures that are widely viewed as beneficial. Examples include receiving annual flu shots and a vaccine to protect against pneumonia, as well as referral for colonoscopy. In the past, the difficulty with a patient with active chronic problems is that it becomes challenging to prioritize more nuanced conversations about a screening test, such as PSA, that may or may not be beneficial and in fact may cause harm. For Mr. A, as is the case with so many other patients, the main focus of his 15-minute clinic visits was addressing the most active issues with an eye toward keeping him out of the hospital. In December 2017, Mr. A presented to a local hospital with symptoms of his emphysema. During this admission, diagnostic tests coincidentally raised concern for metastatic prostate cancer. The diagnosis was confirmed by biopsy the same month. Fortunately, he was immediately started on medical therapy, and he is now asymptomatic with a PSA that has been mostly suppressed. I offer this story to illustrate the inherent past challenges of prioritizing prostate cancer screening in patients like Mr. A. In addition to his medical problems, Mr. A's life circumstances, including competing dependent care responsibilities for both his mother and newly adopted grandchildren, presented challenges to his ability to access all care, including screening. The prior state of the existing evidence made it very difficult either to engage patients in participatory decision-making or to create a structured program with built-in redundancy for a screening tool that might actually harm more patients than it helped. Fast forward to today, and the change in the USPSTF recommendations does provide the foundation for the development of more standardized prostate cancer screening efforts. With more narrowly defined age range and guidance on having tailored conversations, providers and patients alike can go in with a uniform understanding of which patients are most likely to benefit while minimizing potential harm. However, this information will need to be widely disseminated to providers and patients alike. In many cases, where screening recommendations are changed or revised, there's always a risk of the change being featured permanently in the lay press for a brief period of time with follow-up to inform the public for a brief period of time without follow-up efforts to inform the public in a more systematic, in-depth manner. In this scenario, patients can become confused at seemingly contradictory guidance on screening. In the case of prostate cancer screening in our population, patients would need to be educated in lay language via media that they are most receptive to. This may include public service announcements on African American media outlets or dissemination through churches and community-based civic groups. In addition to patient education efforts, providers too need to be educated and trained on two levels. First, providers have to be made aware that guidelines have changed. The article that appeared in the Journal of the American Medical Association, as well as, it sounds like, many multimedia sources of information on the website, need to be accessed by physicians. With all those sources of information notwithstanding, the report also showed that no less than 5 North American physician professional groups or advocacy organizations had some overlapping recommendations for prostate cancer screening. Yet the organizations also disseminated some divergent recommendations as well, ranging from don't screen to screen certain age groups to have an individual conversation about screening with patients. While perfect unanimity among different professional and advocacy bodies may be an elusive goal, hopefully the newly reviewed evidence and the subsequently revised USPSTF guidelines will minimize the discrepancies and recommendations among these organizations. If providers of all type, regardless of specialty and credentials, are hearing roughly the same guidance on prostate cancer screening, it would hopefully bode well for that message being relayed more consistently to patients. Furthermore, individual healthcare institutions can play a role by adopting the revised guidelines as internal quality measures to promote adherence among individual providers. Lastly, insurance companies as third-party payers have the ability to ratify these prostate cancer screening recommendations by including them among their covered services or among their best practices for their insured patients. The second level of provider education is instruction and training on how to have a nuanced conversation with patients regarding prostate cancer screening. While the revised guidelines specify new age criteria for screening, there still was insufficient evidence to make specific recommendations for those at higher risk, including African American men and those with a family history of prostate cancer. These subgroups, which are prevalent in our population, still require a more nuanced approach, and many providers may not be skilled at conveying the uncertainty of prostate cancer screening in high-risk groups. Therefore, even after providers learn about the new guidelines, many providers would likely benefit from training on how best to approach those high-risk groups, still requiring a more individualized approach. Our patient population is complex due to a combination of their high chronic disease burden and a disproportionate share of psychosocial barriers to accessing and receiving care. These factors can make screening difficult because screening is only the beginning of the entire care continuum that proceeds to diagnosis, treatment, and hopefully survivorship. In order for many patient populations to successfully traverse this continuum, structured programs with care coordination are needed. Let's consider breast and colon cancer screening for a moment. Admittedly, mammograms and colonoscopies have vastly more supporting evidence for preventing deaths from breast and colon cancer, respectively, compared to the impact of PSA testing on mortality from prostate cancer. However, mammogram and colonoscopy screening programs are usually run by multidisciplinary teams with built-in redundancies. The structure of these programs ensures that ordering and follow-up of breast and colon cancer screening tests is rarely solely reliant on a single provider or any other individual. Instead, the programs are set up with multiple persons, ensuring that patients receive the appropriate screenings at the appropriate ages at appropriate intervals. In particular, for populations like ours at Cooper Green, care coordination has been essential to ensure that patients do not fall through the cracks. Patient navigators are laypersons trained to assist patients in avoiding the logistical and financial hurdles patients often encounter in most healthcare systems, while also providing emotional support to patients. As laypersons, patient navigators are often better suited to provide tailored support to patients and bridge gaps in communication between providers and patients. In light of these new, more specific recommendations, these are all examples of desirable features of prostate cancer screening programs. The care coordination, redundancy, and lay outreach would likely improve screening rates for the appropriate patients and better ensure that those diagnosed with prostate cancer go on to receive the appropriate therapy. Again, thank you for the opportunity to address this audience today. I hope that our experience at Cooper Green helps to shed light on both the screening challenges as well as the wonderful opportunities to improve prostate cancer screening in patient populations like ours. Thank you.